Hasaballa Phosphate binders update and with iron preparations. اتفضل يا استاذ. استاذ الدكتور ماهر حسب طبعا غني عن التعريف، عضو مجلس اداره الجمعيه العلميه، استاذ امراض البطنه والميكروبي الفصل العيني. يعني غني عن التعريف، مش هقدر اعرفها يعني انا صغير جدا ان انا اعرفها يعني.
Thank you very much. Bismillahirrahmanirrahim. I'd like to thank Dr. Magdi and the organizing committee for inviting me to give this speech, and I'm really proud to be a part of this fruitful gathering. And my talk today is going to be on phosphate binders, update on iron therapy. And our agenda will include phosphate homeostasis and CKD in short, and the problem of phosphate, treatment of hyperphosphatemia, phosphate binders, and the focus on iron-based phosphate binders. So, the phosphate that we have in the blood comes from the food we eat, and it's supposed to be completely excreted by the kidney, and 90% of it is going to be reabsorbed. And most of the phosphate is going to be present intracellularly and in the bones. And the mechanism of absorption and reabsorption occurs through the sodium-dependent phosphate co-transport proteins, which is in itself a therapeutic target, as we're going to mention later on. So in the presence of CKD, it is going to be the renal excretion of phosphate is going to be gradually declining, as you can see here, and this is going to call for compensatory mechanism, which is going to be the parathyroid hormone and FGF23, and these are actually phosphatouric factors. We're going to try to increase the excretion of phosphorus, but not for a very long time, because this, together with the low and high turnover bone disease, we're going to have a rise in phosphate in advanced stages of CKD. But you can see that the trend to hyperphosphatemia is there prior, in earlier stages, as evidenced by the increase in PTH and FGF23. So what is the problem of hyperphosphatemia? Why are we so very much concerned with it? Well, this study was done by Kestenbone on almost 3,500 patients, and it shows that with increasing level of serum phosphorus, there is increased likelihood of all-cause mortality. For every 1 milligram per deciliter increase in phosphorus, there is 24 to 33% likelihood of increased all-cause mortality, and this was as strong predictor as age, diabetes, congestive heart failure, CKD stage 4 and 5, and anemia. This does not only apply to end-stage and advanced kidney disease, because this study was done by Tonelli, CKD stage 2, and here the estimated GFR was around 76 milliliters per minute, which is not bad. And those patients were followed up after the first coronary attack for 5 years, and they were divided into 4 quartiles, and it was also found that the higher the phosphorus, even in a high normal level, was associated with the increase in all-cause mortality, coronary death, and non-fatal myocardial infarction, and the occurrence of new congestive heart failure. Even in the general population, this study comes from the Pharmacological study, and these are patients, but not patients. They are individuals with no cardiovascular risk whatsoever, and they are not even CKD patients. They have eGFR of more than 100 milliliters per minute, and in spite of that, the higher the phosphorus, the more the hazard risk for cardiovascular disease. So phosphorus seems to be deleterious for the cardiovascular health in normal individuals, and it has been very interesting. It has been associated with accelerated aging these days. So it seems that even the general population were sharing the treatment with phosphate binders. Now this goes to our dialysis population. You can also see that the higher the phosphorus, the greater is the risk for mortality. And of course, you can all notice that it's a U-shaped curve, because the lower the phosphorus, there's also an increased risk of mortality because of the presence of malnutrition. So phosphorus now seems to be the most important toxins in renal patients. And why is that? Well, you know that phosphorus, what it does, it regulates the gene expression in the smooth muscle cell. The influx of phosphorus is going to be a shutting down of the smooth muscle cell gene, and is going to be upregulation of the CD5FA1, and this is going to cause transdifferentiation of the smooth muscle cells into a phenotype of osteoblastic phenotype. So the cell is going to start to excrete alkaline phosphatase and calcium binding proteins and bone-specific collagen, and even you can see calcium phosphate loaded matrix vesicles, and this is going to result in matrix mineralization. And by the time the patient comes to dialysis, almost 50 to 100% of them, they have pathologic vascular calcifications, either in the intima or in the medial smooth muscles, as evidenced by special stains. So, therefore, treatment of hyperphosphatemia is a very important challenge in the management of patients on dialysis, and this can be addressed through the diet, the phosphate binders, dialysis intensification, and treatment of hyperparathyroidism. Well, of course, the diet does not answer the question, because you all know how patients are non-compliant. And even if they do comply, they're going to go into a 13-calorie malnutrition, and this in itself is an important cause of morbidity and mortality, and it's going to outweigh the benefit obtained by reduction in phosphorus. And of course, you know that the traditional dialysis does not lower the phosphorus well enough. So phosphate binders become a very important tool in the management of dialysis patients having hyperphosphatemia. We have many binders, as you all know, including the calcium-based binders, and the sevelamer, the lanthanum carbonate, and they all seem to be working very efficiently, and they all could reduce the serum phosphate levels to that recommended by the KDOQI guidelines. But what is the problem then? The problem is the adherence, because the lack of adherence results in it's actually an obstacle to effective therapy. And this comes from the French people, not from Egypt, and it shows that almost 49% only of patients are controlled according to the KDOQI guidelines. So for phosphate binders to be ideal, they have to be effective to bind large phosphates regardless of pH. They have to have minimal systemic absorption, few side effects. They also have to have a good palatability and low pill burden, and of course to have a low cost, because the patient is probably going to be maintained on that. We know that phosphate binders results in formation of non-absorbable complexes that pass into the feces, but in fact many of those binders are absorbed, and of course this effect is not desired. Well, let's review together the current phosphate binders that we have here. And the first that was introduced in 1980 was the aluminium hydroxide, and then it proved to result in aluminium intoxication. And then came the calcium-based binders, both the calcium carbonate and the calcium acetate, and then was the problem of calcification. This was a big problem actually, but it is in wide use because it combines both the efficacy and the low cost. Then we have the sevelamer, and well, this sevelamer does not produce any aluminium intoxication, no hypercalcemia, but it's not very, very effective. So the problem with it is the big pill burden, and it is expensive. And now the lanthanum carbonate was introduced in the year 2005, and this one is very good, has no much side effects, no increase in calcium. It is very effective, so it has the added benefit of a low pill burden, but the problem again is that it is expensive. So we have proof that the use of phosphate binders, irrespective of the type of phosphate binders, is associated with a reduction in the progression of calcifications. And these are the patients that are maintained on low phosphate diets, and these are maintained on calcium carbonate, and these are maintained on sevelamer. And there is a difference between those who are not receiving any phosphate binders to the rest. And of course, you have many papers stating that it's better with the sevelamer than with the calcium carbonates, and we have other studies denoting the opposite. And also, we have reason to believe that the use of phosphate binders is associated also not only with the reduction in calcification, but also with a better survival in RDT patients and in general. But again, there are an indication that maybe the non-calcium-based binders are better in the gods, and again, there are other papers that are pointing to the opposite. So we really need head-to-head comparative studies with the phosphate binders and for longer periods of time to get up with the best phosphate binder to use. Now, I'd like to share with you the new pharmacological approaches targeting the phosphate overload. We have the Renazorb, which is a second-generation lanthanum-based binders, and it just finished the phase 1 randomized controlled trials. And we have the polymer-based binders. There are 3 of them. We have the Calcification, which is marketed in Japan and Europe, and we have the big star Numer, which is launched in Japan in the year 2012. And we have the citrulline chewing gums, which has finished phase 1 trial. And we have this very interesting different mode of action, which is a nicotinamide. It acts through inhibition of the sodium-dependent phosphate transporters that you just mentioned. Well, phase 3s are going, but it seems to be associated with a lot of GIT side effects. Now we come to the iron-based phosphate binders and the use of iron. You know, iron is a cation that is well known to have the capacity to bind phosphorus. And this knowledge has been there for the last 80 years. So we cannot actually say that this is a new idea or a new thing. We know that ferric compounds can bind phosphorus in the gut when they're given orally and even parenterally. But the thing is that before the use of ESAs, treatment of anemia was done through blood transfusion. So the patients were iron overloaded, and it was not an option to give phosphate binders in the form of iron. But then in the era of ESAs, there is iron deficiency because of the use of ESAs and because of their repeated blood loss due to sampling and because of dialysis and because of the impaired iron absorption due to increased level of hepcidin and because of the use of drugs like the PPIs and the phosphate binders. So now there is a place for these drugs. And actually we have 4 iron preparations that are now being tested. We have the Pharmacological, which is an iron magnesium hydroxycarbonate, and we have the SBR759, which is a polymeric complex, and these 2, the development has been terminated because of lack of optimal effect and because of adverse side effects. Now the remaining 2 compounds is the Zernex, which is a ferric citrate, and this has been launched in Japan, has been authorized in Japan and filed for authorization in the US FDA and in the EMA, which is the European Medicines Agency. And we have also the superferric oxyhydroxide, which is the PA21, which was launched in the US this year in 2014. Now, the Pharmacological was associated with a worse control of hyperphosphatemia compared to the other binders, and a poor GIT tolerance and increased pill burden, so it really did not offer much compared to the other binders. Although there is an intention to restart phase 3 trials later this year and it's supposed to be completed by the year 2017, but it's not likely that it will reach the market successfully. The SBR759 has the same problems as the Pharmacological in Western population, so there is ethnic differences, and it has the other problem of increased iron absorption with tripling of serum ferritin. So there is concern about the iron absorption, and it's also not likely that it will come to the surface. Now the other 2 compounds, the ferric citrate, it has the same GIT profile as Renagel, but it has the problem of increased pill burden and of course also iron absorption. It is in phase 2 and 3 studies in Europe and Japan for the treatment of patients prior to dialysis for those patients who have hyperphosphatemia and iron deficiency. Then we have the PA21, and this one is, has the problem of GIT upsets more than Sevelamer, but it has the benefit of a low pill burden. So this is, of course, it was associated with more adherence when compared to Sevelamer. So it will depend on the cost, how expensive it's going to be. So when you compare these 2 drugs that are already on the market, you will find that we can use ferric citrate in patients who have iron deficiency requiring iron therapy, and this is going to be a concern in patients with good iron stores. And we can use the superferric oxyhydroxide in those who do not have iron deficiency. But also this one has the very good benefit of having a low pill burden, so this is going to improve adherence. Now if you look here, this is to show you the number of pills of the new superferric hydroxide PA21 compared to Sevelamer, and this is Sevelamer carbonate.
5 minutes.
Yeah, 5 minutes. And of course, this is going to improve adherence, but adherence has been addressed before with the lanthanum carbonate. So unless it's going to be less expensive, it wouldn't add much actually. And also we have the problem of GIT abscess, and this is to show you with the diarrhea, for instance, and though in spite of the fact that it occurs only initially and is transient, that it has resulted in cessation of therapy in a number of patients, as you can see here. All the GIT manifestations are higher than with sevelamer. Only constipation is more common with sevelamer. So, if you ask what is going to be the future, again, I think the notion of having a low liver is very good and it's very much welcome, but again, we have to continue searching for the best binder, and just to tell you that not just as important as the patient education. The patient will have to be educated about why and how and when to take the drug. And I end up my talk with the quotations which states that the effective phosphate binder yet discovered is the one that the patient will take. Thank you very much.
Thank you, Professor May. 2 questions, please. Okay, Rakesh.
Thank you, Professor May, for your excellent presentation. Regarding what is known as iron preparation, does it work like other iron for, replenishing iron stores in addition to their phosphate binding capacity?
If you're going to talk about the 2 drugs that are already in the market, one of them, which is the ferric citrate, is more absorbed in the gut than the PA21. So the ferric citrate is now undergoing phase 2 and 3 trials to be used also as an iron supplement in patients with iron deficiency. But it's not going to be suitable for those who do not have iron deficiency.
Yeah. Okay, thank you.
I think the ransom already is causing constipation.
Yeah.
So we are, with the progression of the medications, we are asking for new drugs, asking for the same complication.
We haven't reached the optimal drug yet, but the lanthanum has the least GIT symptoms.
Any more questions? Thank you, Professor Mike.
Thank you.